Welcome to the Nursing Post podcast, all nursing all the time with Ashley Moore and Rosa Horsley. Today, during Sleep Week, we will be discussing obstructive sleep apnea, or OSA. As always, our goal is to inform and to help start conversation.
So I remember when I was in nursing school reading a very few small paragraphs about OSA and treatment.
Yep.
Literally 2 paragraphs. And since nursing school, since I've been doing this, 11 or 12 years now, a lot regarding OSA has changed. And the thought process used to be that you only had sleep apnea if you were overweight or obese. But now we know, and science has proven that to be false.
Yes, absolutely.
You'll hear general signs and symptoms and some general statements of, oh, you snore, then you probably have sleep apnea, this, that, and the third. So ask yourself, does your significant other complain of you snoring? Do you wake up and feel as though you never slept? Are you prone to headaches? Maybe this episode could be for you or your spouse.
Right, absolutely.
It's very good conversation. It's very good knowledge, and it's a lot to know. And I work in sleep, and I didn't realize how much I would enjoy it. It sounds boring, right? Sleep. Oh, there's so much excitement in a sleep clinic. No,
I guess it depends on who you are.
But I've learned so much, and so with it being Sleep Week, I'm just excited to kind of share it with everybody else. And you used to work sleep too, so.
Yes, I didn't find as much passion and joy as Rosa does with it, but it is something that once you learn about it, you can't unlearn it. Even to this day, when I hear people talk about somebody else snoring or you look at their neck and you're like, it's awful. It's true though. I'm like,
That's funny because actually this week I had that conversation with one of the sleep docs, and he's like, do you realize how many people have sleep apnea? And I turned to him and I said, well, we all can't be giraffes. And he gave me this look because he couldn't comprehend what I was saying. And he turned to me and he said, they can't be what? And I was like, giraffes, long necks.
Long skinny necks.
And he was like, oh my God, no, you're right. They're hippos. We're seeing hippos.
Yeah, if you can't see a well-defined neck, they probably have sleep apnea. And that's very generalized, and anybody who works in sleep is probably saying yup. But if you haven't ever worked in it, you don't, any job that you work where you do the same thing over and over again, you start picking up on things. At dermatology, I'm sure people can, spot a mole from 10 miles away.
You need to make an appointment because that can be cancerous.
Right. And I'm like, it's a mole, whatever. And so everybody gets their little
niches. Yeah. So now when I stand in the line at the grocery store and I'm checking out people, I'm like, oh, that's a no neck. That's a long neck. Like maybe that person has sleep apnea. I don't think that person does.
Absolutely.
But it's not even based on this preconceived notion like in the past that it was all based upon weight. Because even a giraffe or an anorexic person can have OSA.
It's not always just about the neck, but about the chin as well. And I remember the very first person that, that kind of clicked with me, and this was years ago. And I'm like, they have OSA? Like, it was bad too. Like, he had severe sleep apnea. And I'm like, this guy's fit. He's young. He is not somebody that would be something you would see in a textbook as, oh, this person has sleep apnea. But he had, like just that retrograde chin, that just fell backward when he slept. It does affect everybody of all sizes.
Yes.
It's more about, do you snore? Do you have those headaches? Do you feel like you not slept? And things like that you can start putting together.
Absolutely. So, of course, we love our stats. Approximately 3 to 7% of men and 2 to 5% of women have sleep apnea. Over 100 million people suffer from sleep apnea worldwide. And it's probably even more than that because these are diagnosed, and a lot of people don't realize that they have some of the signs and symptoms to even go get tested. So I honestly feel that there's probably more than 100 million people suffering worldwide from sleep apnea.
Sure.
An estimated 22 million suffer from moderate to severe sleep apnea. And 1 in 12 people in America suffer from obstructive sleep apnea.
Right. And there are different types of sleep apnea, which is why we're stating obstructive sleep apnea, because it is different.
There are different types, but we're focusing on, I think, the most common.
This is, yep.
Which is obstructive sleep apnea.
So just to kind of give some basic overview of what OSA is, it causes your breathing to stop over and over and over again. So you stop and then you start back. You stop and you start back. And this happens while you're sleeping. Like we were saying before, there are many different types of sleep apnea, but obstructive sleep apnea is the most common. And that happens when your throat muscles intermittently relax and then block your airway during sleep. Now, a lot of people will say, I sleep just fine, but they're not actually getting into that deep sleep because their body wakes them up enough to take a breath. Mm-hmm. And then they go back and try to go back into a deeper sleep, but they don't actually wake up necessarily.
It doesn't take you out of that state of sleep.
Right.
So what happens is when you stop breathing, your brain then tells you to take, like, gasp, breathe.
Right.
It wakes you up enough to breathe, but doesn't wake you up out of your sleep.
Exactly.
So most people, if you live alone, you don't have a significant other, like, they don't know that they even have it. Like, how many times do you hear yourself snore a night? How can you if you're asleep? So, I mean, how do you know that you're even waking up in the middle of the night, gasping for air if you're asleep?
Right. And you'll hear, and I always felt, and Rosa, you may have a different opinion about this, but that the men would come in and say, I sleep just fine, but my wife keeps saying that I
keep snoring too much, and if I don't do something about it, I'm going to have to sleep in another room.
Right. And that's what brings them in.
It's not them, it's their wife.
Exactly, because either they're snoring or they're literally watching them stop breathing. And then gasp, and it scares them.
Oh, yeah. They come in all the time saying, I don't know why I'm here. I sleep just fine. Yeah. It's my wife. She made me do it.
Exactly. And so, and I always felt like I heard that more from the men than I did from the women.
I hear it from ladies, but it's very few and far between.
Right.
And most of the ladies, and we'll talk about this later, complain about the treatment of sleep apnea.
Oh,
so
yes.
We'll talk about that later. We have already started telling you some of the signs and symptoms.
Right.
So we'll just go ahead and continue from here. Excessive daytime sleepiness or fatigue. You know that feeling like you're tired all day long, like you just didn't get enough rest. So you're tired throughout the day. You start getting sleepy after lunch, you're unrefreshed. You have loud or frequent snoring. You have silent pauses and breathing while you're sleeping. You're making choking or gasping sounds while you're sleeping. Maybe your significant other has observed these episodes where you have stopped breathing when you're asleep. Morning headaches, migraines are sometimes a symptom of that. Difficulty concentrating during the day. It's hard to concentrate when your body is not adequately rested. It's hard to maintain focus. So you tend to forget things. So memory loss, mood changes such as depression or irritability. I'll tell you right now, I'm not a morning person. You probably don't even want to say hello to me until after I've had my first cup. And that's on a good day.
Oh, absolutely. Well, I think that I'm for sure that way. I have a wonderful husband who usually has that brewing.
And ready for you. Because he knows. He wants the nice Ashley. He doesn't want this irritable Ashley.
There's no such thing. That's one of the things that some people, when they first wake up, they're kind of in a grog. And I think some people with sleep apnea feel like they'd never get out of that grog.
Yeah. They're just kind of literally Oscar the Grouch comes to mind.
Yeah.
High blood pressure is a sign and symptom of sleep apnea. Nighttime sweating, decreased sexual desire. I'm telling you, if I'm tired and, my husband's like tapping on my shoulder and I have the opportunity to sleep, I'm going to sleep. I love you, baby, but I'm going to sleep. Insomnia. Sometimes you can't sleep. Sometimes you're just so exhausted. Have you ever been so exhausted? Like you You can't sleep.
Now, girl, you know you and I are on different wavelengths when it comes to
I'm
the
the insomniac.
Give me a blanket and a pillow.
Let me tell you, Ashley takes coffee and can roll over and go to bed.
Yes.
If I take coffee that late at night, somebody's going to be peeling me off the freaking ceiling.
No.
Because I already can't sleep.
No, I fell asleep on the couch while drinking coffee last night.
She does not have any of these problems, let me tell you.
I don't. Thank God, because I would be a grumpy person. I'm
you
going
would
to
be
tell
Oscar
you.
the Grouch at that point.
Yeah. Oscar and I would be good friends.
I'd be like, Oscar, you need to move over because I got to get in there with you. And nocturia, which the former urology nurse in me can tell you that that's frequent nighttime urination.
Yeah.
So those are some of the signs and symptoms. You don't have to have all of these, but most of the time, like Ashley and I said, the ones that bring people to the doctor's office are, my wife says I snore too much, and if I don't get this fixed, she's going to kick me out of the bedroom.
Yep.
And then the second one is, she says I stop breathing, and she's terrified for me.
Yes.
So I'm here because of that.
We do want to go over some risk factors. These things don't mean that you have sleep apnea. It just means that you're at higher risk for developing it. Excessive weight. So as your weight increases, you can just think that your chance of sleep apnea increases. It pretty much goes hand in hand. And we're talking about a BMI of 25 or more, puts you at overweight, and then a BMI of 30 or higher, you're considered obese. So even just a little bit of weight out of your normal range can put you at risk
because
for
when we
sleep
gain
apnea.
weight, I mean, we have to be practical about this. When we gain weight, we would, as women, we would love for it to go to the top or the bottom, but it doesn't necessarily work that way.
It never goes where you want it to go.
It never goes where you want it to go. So it hangs around where? Your neck, your love handles, and the places that are not necessarily good for you health-wise.
Correct. And then if you have a larger size neck, and we're talking about a neck size of 17 inches or more for men, or 16 inches or more for women. And so a large neck has more soft tissue that can block your airway during sleep because you actually gain weight around your neck.
Absolutely.
And we're talking about obstructive sleep apnea. So it's doing that. That fat is literally helping obstruct your airway.
Absolutely.
And middle age, believe it or not, sleep apnea can occur at any age. There are even kids that have sleep apnea that are small and active, not just obese kids, but there are kids that have sleep apnea. But it becomes more common between young adulthood and middle age.
Absolutely. And I think people need to realize, if you're a nurse, it kind of makes sense. The older you get, the less tone you have in your body. So your skin gets thinner because you don't have that elasticity of the collagen, things kind of, gravity takes a hold of you. So that's why one of the symptoms or risk factors, is your age.
Right. And males are more prone to have sleep apnea than women, but women do get a higher chance of sleep apnea with menopause. So thank you for that, because menopause alone is not enough, but you may get
the whole cycle that we had up until we reached menopause. And now we're still suffering after menopause.
Right. And then, of course, a lot of women with menopause gain weight.
Because of the hormones.
Right. And so there's a lot of different factors, and you can start tying these all together. And high blood pressure is very common for people who have sleep apnea. And I have seen, Rosa, I know you have people who have come in with high blood pressure, 160s over 90s, who get treated, and then that number drops dramatically.
When they're compliant, yes.
Yes.
When they're compliant.
That little caveat. Yeah, you just don't get diagnosed. You actually have to treat your sleep apnea, which Rosa's going to talk about here in just a second. And then a family history of sleep apnea does come into it. It's partially a heritable condition. You may be at higher risk if your family members have it. And there are other things, physical features that can come into play. You look like your parents.
Well, yeah, if you're born into a family that already has a diagnosis, you know what I'm saying? Like your mom has it, your dad has it, your brothers have it, or what have you. Whether they're long necks or not, you're more susceptible because that's genetic.
And I think it's funny because I have a long, skinny neck that I've always been kind of, I don't know, self-conscious a little bit of. And then after working in sleep and realizing that I probably won't ever have to deal with this issue as long as I don't, become like morbidly obese or anything, I was like, whew.
It's a
Thank
sigh of
goodness.
relief, right? You're like, this neck of mine all my life, I've been self-conscious of it. And now you're like, I'm going to tie my hair up. I'm not going to wear a scarf today. I love this neck.
It's so pretty.
So the only way to really know if you have sleep apnea is to rule it out, right? So
yes.
What we do in sleep is diagnostic testing for it.
Mm-hmm.
And so the easiest one, I would say, is the home sleep study test.
For sure.
It might not be comfortable, but I feel like it's more comfortable than an in-lab setting. So for the home sleep study test, you do have to meet certain criteria. People who do the home sleep study test do not have a high risk of obstructive sleep apnea. Like I said, we're trying to rule things out. Basically, either you have it or you don't. You want to make sure that your physician doesn't suspect that you might have other sleep disorders. So a home sleep study test might not necessarily be beneficial to someone who the physician thinks might also have narcolepsy.
Right. Or parasomnia or something like that.
And other things like that.
Sure.
Or even complex sleep apnea, which is a different type that we're not really going to discuss. But a home sleep study test probably would not be the best indicator of that.
Yeah, I know a lot of that. Unfortunately, if that comes back on the home study, it usually means you're going to have an in-lab.
Absolutely. And if you have certain medical conditions, including pulmonary diseases, neuromuscular diseases, or congestive heart failure, you're probably not wanting to do a home sleep study. Yes, it is convenient. I've had a home sleep study done. It's not very difficult. You literally have a belt with a monitor that is wrapped around your chest. You have a pulse ox on your finger, and you have a nasal cannula that does not dispense any oxygen to you.
Right.
And while you're sleeping with the device, the pulse ox, and the nasal cannula in your nose, it's recording data. It's recording, the rise and fall of your chest. It's recording your respirations. It's recording your oxygen rate, making sure that you're not having desaturations while you're sleeping. And of course, it's monitoring for those episodes where you're not breathing.
Right. And how long?
And for how long? Absolutely.
Why don't you explain, you touched on the fact that you wear a nasal cannula, but that it's not actually delivering anything. What's the purpose of it then?
So there's two kinds. There's just like a plain nasal cannula that are two prongs that you put in your nose. And some studies, they use what's called an oral nasal cannula. So that one has the two nasal prongs, but it has a J hook that you would put into your mouth. And the purpose for that is people snore. So this also picks up on snoring, but it also picks up every time you gasp.
Yeah.
Which is super important to know whether or not you have possible sleep apnea. So it's funny because I do the education for this.
Yes.
And every time I tell somebody the J hook goes into your mouth, they all give me that look like deer in the headlights.
Yes.
And so, I always have to make that little joke. This is why I save that for last, because I get, so many people freaking out about it, but it's not that scary. You know what I mean?
Well, I think so many people think, it goes in my mouth, but it really just rests right at the upper lip.
At the upper lip. Just enough to.
So it's not. Yeah. It's not intrusive. It's just different.
It's just different from them. And, it's actually a really good indicator. Like, it'll even tell you how loud you're snoring.
Oh, and I'm going to tell you, if anybody is getting a home study and they've been for an in-lab study, they are fine with a J hook. I'm telling you, absolutely. and for another reason is, I know where I currently work, it's less than $300. To do this study. Significantly.
It's so much cheaper and less inexpensive to do the study at home if you're able to than it is to be done in lab.
Oh, yeah. And that's without insurance.
Exactly. $300 without insurance. Yeah, they'll bill your insurance out. Everybody's insurance is different, but it's less expensive. So the other way to diagnose this is with an in-lab sleep study. So that would be polysomnography, a split study, or a titration study, which would be titration from a CPAP device to a BiPAP device to an ASV device. And or if they're trying to rule out narcolepsy or any other type of sleep disorders, would be a multiple sleep latency test. It is recommended to have an in-lab study to test for sleep-related breathing disorders, such as sleep apnea, to evaluate behaviors during sleep due to parasomnias, like I've already said, to diagnose narcolepsy or hypersomnia, and to titrate or calibrate the levels of continuous positive airway pressure in patients who have previously received and are currently using a CPAP device for sleep-related breathing disorders, and also to determine why treatment for a patient may not necessarily be working.
You really don't think of sleep being in depth, but I mean, we could do a whole podcast on each type
one of these,
of device that you use in titrations and the different studies. You just have to understand that when people come in and they're like, oh, I want a BiPAP, that's different than a CPAP.
Absolutely.
And if they're on an ASV machine, that's completely different than a BiPAP or CPAP. Mm-hmm. And they do different things. So just making sure that you have an accurate history is really important.
I mean, and they will do that when you're going in for your consult. They're going to make you fill out an Epworth sleepiness scale. Yep. It has all these questions on it about the probabilities of you falling asleep while doing different activities.
Right.
And we'll link that, as part of a screening tool that maybe you can go and sit and discuss with your physician at your next appointment if your significant other is like, hey, you snore, or I saw you stop breathing.
And trust me, I don't think there's a physician in the United States that doesn't know what a sleep apnea is.
No, not anymore. I think, like I said, back in the day, it was more stereotypical, but because sleep medicine has come a long way and it is now really prevalent, OSA is very prevalent. Your family doctor can set you up for a home sleep study test or an in-lab. So if you're having these issues and you don't know where to start, your PCP is a good place.
Oh, absolutely. So there are a couple of different types of treatment that we'll go into, and I touched a little bit on that just a second ago. If you have a very mild case of sleep apnea, and let's say you don't really have any other medical conditions and you don't feel tired, and mild starts at 5, a number of events being at 5, and I'm a 6. But I feel okay. I don't have headaches. I don't have any issues. I don't have blood pressure issues. I may not move forward with treatment. And the doctors will say that's okay. But they may say, oh, well, you had more events when you laid on your back, or when you laid on your side, or when you laid on your stomach. So here you get some wedges, do some positional sleeping, and sleep in these positions and try to treat it that way instead of being treated with some type of positive pressure. Another thing is they may say, yeah, Ashley, you're kind of, inching that scale up a little bit. If you lost 10 or 15 pounds, this could bring it down. Even if you have bad sleep apnea that needs to be treated, if you're overweight, they're going to tell you to lose weight because it will help.
It does.
It's not fun, but it absolutely will make a difference. There are some lifestyle changes that you can make to help either reduce your snoring or improve your sleep apnea symptoms. Exercising regularly, that goes back to, kind of the weight. If you drink alcohol, you want to make sure that you don't overdrink and try not to drink several hours before bedtime. A lot of people think that they sleep better when they've consumed alcohol, but actually
that's a myth.
You don't. Alcohol relaxes your throat muscles, and we talked earlier that actually causes you to obstruct your airway and you can start snoring. So you may know somebody who you're like, they don't ever snore until they're drinking, and this is why. Quit smoking if you do. You can use a nasal decongestant or allergy medicine just so that way you have better airflow. And don't sleep on your back. It's best to sleep on your side. Some people are not comfortable that way.
I'm going to tell you this. If you told me that I don't have to have therapy, medication, or equipment by sleeping on my side, I'm going to sacrifice sleeping on my back and I'm going to sleep on my side.
Right. In my years of being a nurse, most people I have found are not willing to make the lifestyle changes.
True.
Unfortunately. And another thing you can do is avoid taking sedative medications or things like the Xanax or like a benzo, anti-anxiety, or sleeping aids, because again, they're relaxing everything and they'll make you more prone.
Yeah, you're talking about, the most frequently used ones are those PM medications. You take 2, it helps you fall asleep.
Yes.
Another form of treatment for obstructive sleep apnea is an oral appliance device, which is also known as OAD. And what it is actually an oral appliance device that you can put into your mouth that helps reduce the amounts of apneas that you have during your sleep. It kind of adjusts your jaw a little forward and helps your tongue from kind of like falling back on your throat, causing some obstruction.
Right.
So if you were interested in one of these, you would probably want to talk to your dentist. Sometimes they have dental labs there on site in which they can measure and fit you for, or if they don't personally, they can refer you to someone that does. Another form of treatment for OSA are your auto titrating PAP devices or your continuous positive airway pressure devices. And these are really the frontline treatment for OSA. CPAP therapy keeps your airway open during the night by gently providing a consistent stream of air through a mask that you wear while you're sleeping. This eliminates the breathing pauses or stops that you're having because of your obstructive sleep apnea. So you'll no longer snore, you'll no longer make those choking and gasping noises in your sleep. You'll be able to sleep throughout the night without your body having to wake itself up and remember to give yourself oxygen or to remember to take that breath in. And of course, there are supplies, that do go with this. It's not just the machine, there's tubing.
Right.
And then there's always the type of mask. And we could do a whole episode on masks alone because there are so many. But for this episode, we're not going to do that. It's funny because the men, they generally just don't care. Like, they're okay with nasal mask, full face mask, whatever.
Right.
But it's my ladies that come in and they're like, oh my God, this thing is so ugly. I don't want to wear it. My husband doesn't think I'm cute when I have to wear it.
He should be asleep.
He shouldn't be looking at you anyway, right? At that point, he should be asleep. I don't know. I get that a lot. And I remember telling one of my patients to just bedazzle it and be done with it. And she just thought that it was like the most hilarious thing she had ever heard. And she was like, you know what? I think I might do that.
It's so funny. I remember a patient, her husband had sleep apnea, had a CPAP. She ended up having it as well and was getting a CPAP. And she was just so upset. And she had left a message about she just did not want to wear this thing. She just did not want to wear it. And she said, you just don't understand. It's like 2 porcupines trying to make love. And I thought,
why
you
don't
put
you
it
just
on?
take it off?
You just don't put it on till you go to sleep. Not when you're in bed, but when you're ready to go to sleep.
Oh my God. Other treatments include surgery.
Yes.
So some of those surgical therapies, they're not as effective in treating sleep apnea as a CPAP or an APAP or an oral appliance device. They can reduce or eliminate some extra tissue in your throat that collapses and blocks your airway when you're sleeping. More complex procedures can even adjust your bone structures, including your jaw, nose, and facial bones. And some people even consider, like weight loss surgery as an option. And one of the most, I would think, invasive would be having to have a trach.
Right.
To kind of like bypass all of your upper airway. And it is the most effective surgical procedure for OSA, and it is 100% effective. But this is only for the patients with like really severe OSA who have tried and just can't tolerate any of the treatments or other surgical procedures that are out there.
Right, because you can have sleep apnea so severe that it can kill you.
Yes.
And so when some people are like, what, a trach? You're going to put a hole in my neck because I snore at night? For some people, it's this or an early death.
Absolutely.
And so it's sad, but it is true. And the only people that I've known that have needed this type of treatment to treat their sleep apnea because they couldn't tolerate anything else are the ones who are morbidly obese. And I'm not talking, and morbidly obese, you know, it happens at one number and then it just indefinitely goes up. I'm talking about patients who are 300, 400, 500 pounds. Like they are, and not like a stocky, you know, football player, 300 pounds kind of thing. Of course, that's still big, but there's a difference when you look at the people that need this. It's
absolutely,
just
and the
their
severity
body
of it
literally can't move that weight to take a breath, and it's just a lot.
And there's a difference between somebody, you know, who stops breathing, you know, 5 times an hour. I mean, we've seen even less than that. I've seen somebody stop breathing 1 time an hour.
Right.
But I've also seen it go as high as somebody like that stopped breathing like over 100 times in 1 hour.
Yeah, I think the highest one I've ever seen was 128.
I think I've seen over 150 something.
Yeah, that's impressive.
Yeah. And so if you're literally, I can't even see how you're breathing at all at that point when you're asleep.
You took it right out. I'm like, at that point, you're just in a constant state of...
I don't even see how you're functioning, to be quite honest.
Right.
But that's how severe some of these cases are. And I don't think people realize that when you're not receiving oxygen, what that does to the rest of your body and why that affects your blood pressure and how that affects the work that it's putting on your heart.
Oh, absolutely. And that's kind of, you know, we're going to talk a little bit about what not treating sleep apnea is here in a second after we talk about this one more little nifty device that's pretty new. But for adults, you can have apneas 1, 2, 3, 4 times an hour, and it's considered normal. Mm-hmm. It starts at 5 and goes up from there. And there's, you know, mild, moderate, and severe.
Correct.
Children, it's not normal for them to have any
at all.
So even if they have 2,
it's treated.
You're treating it. If you come as an adult and you have 2 events, you're not getting treated, and your insurance isn't going to pay for it to be treated either. No. So there is a big difference on how things are treated depending upon the severity and your symptoms and what other health conditions you have.
Absolutely. So I've been doing sleep now for about like a year and a half, and within that year and a half, our facility has kind of partnered up with the Inspire company. Mm-hmm. And it's called an Inspire device. And what it is, it's a small device that's placed. It's a same-day procedure, outpatient procedure. And what it does is when the patient's ready for bed, they click a remote to turn the Inspire on. And while you're asleep, Inspire opens the patient's airway, allowing them to breathe normally and sleep peacefully. And there are some criteria that you do have to meet in order to have this device implanted. You have to have moderate to severe OSA, which means you have to stop breathing, 15 to 65 times an hour. Mm-hmm. While you're asleep at night. You have to be free of complete concentric collapses at the palate. This device would not probably be good for you if you have like a cleft palate. Mm-hmm. Unable to get consistent benefit from the CPAP. So you've literally exhausted every possible use of that CPAP and you are still suffering with no relief. If you're significantly overweight, you don't qualify for this, and you have to be at least 22 years of age or older to be considered for having this device.
Now, you got to tell them how does this device actually keep the airway open? Because I'm going to tell you, it's interesting. And you know more about it than I do.
It's basically a pacemaker. Mm-hmm. That is implanted, and instead of it being wired to your heart, mm-hmm. like a normal pacemaker would be, it's actually wired to the muscles in your tongue and throat. So when you're turning that remote on before you go to sleep, what you're turning on is the stimulation to your tongue and your throat. And what it's doing is it's pushing your tongue
out of your airway.
Towards your teeth and towards your lips to move it, obstructing your throat and airway.
Right. It was amazing to me that we can implant a device that sends, pretty much, to me, it's almost like impulses to a muscle so that muscle contracts and moves out of your airway. I'm like, this is crazy.
It's not crazy to me because the former urology nurse that I am saw these placements. Medtronics does these, makes these devices. And when I was working in urology, we would use them for patients who had no successful treatment with overactive bladder. Like they've been through every medicine. They did physical therapy, pelvic floor therapy.
Right.
They've been through the gambit. So they started this new procedure where they would implant a pacemaker and attach the wires pretty much to your sacral area where all your signals come to let you know that you have to use the bathroom. And so it would fix a lot of urgency episodes and frequency episodes that our overactive bladder patients had. I was, however, surprised when they started using this to treat sleep apnea. It just wasn't so much of a foreign concept because I had known that it had been used in other things. Very interesting to watch, though. But it's important that if you have sleep apnea, that you get it treated. And Ashley's going to tell us why.
Untreated sleep apnea can lead to long-term negative consequences to your health. And a lot of that is a lack of oxygen. And I think that most people know that you need oxygen. You need to be able to breathe to live. And if you don't, there are consequences. It's back to the ABCs. So there are 5 big things that Rosa and I picked for negative consequences of untreated sleep apnea. The first one's high blood pressure.
We've already discussed that.
And we have a whole podcast on high blood pressure.
Yes.
And with that comes heart disease.
Which I think we've also done a podcast on.
And stroke.
Which we've also done a podcast on.
Pre-diabetes and diabetes. Which we have not.
Yes.
And depression.
Which we have done.
And if you actually go back to any one of these, maintaining a healthy lifestyle is a key contributing factor to correcting or preventing any disease to progress. And that's, to me,
that's everything.
That's
medical.
everything.
Just imagine if everybody prevented and led a healthy lifestyle, how many doctors wouldn't have employment?
Well, not only that, but at that point, because I think that even if some people do everything that they can, they're still going to have issues.
Absolutely.
But at that, I feel like maybe we would have more time to work on things in our healthcare system that needed help, like getting patients the assistance that they need for their medicines, or helping the patient that needs to be there for an hour to talk to their doctor about their depression. I mean, at that point, the concept of medicine would change.
Absolutely. I think it would be more efficient.
In Ashley's perfect world.
Coming in 2085.
Yes, exactly. When I'm not here to see it. So we're going to finish up this episode with nursing considerations, things that we find to be important. And then if you want to start that off, Rosa.
Sure. Of course, compliance.
Yay.
I don't know how many patients come in and, they're like, man, I just can't get that good night's rest. And I'm so tired all the time. And my headaches won't go away. And then you go to pull up their compliance and they've maybe used their device 1 hour in like 90 days.
And that was the hour right before they came to the doctor's office.
Yes, the night before. I see that a lot. Or they turn it on a week before they come to the doctor's office and say, yes, I've been using it every night. But the reason why we're sitting here kind of not harping, but just strongly, encouraging for patients to be compliant is because you need that oxygen.
Mm-hmm.
That oxygen deprivation is doing more damage to you than you using your device. So we so much educate, like I think 95% of the people, how important compliance is. And you don't want your apnea to lead to worse apneas. Because as we said, we're talking about OSA, but there's a couple of different forms of sleep apnea.
Yeah, in my opinion, and if this is strictly my opinion, this is probably the easiest to treat.
Yes.
And the place you want to stop.
Yes. Perfectly said. So even if it's with a PAP device with an ugly mask that you have to bedazzle, or putting in your oral appliance device,
right,
or using a bump guard to sleep in so that you don't roll over on your back, like, be compliant.
Yes.
You want to educate your patients on proper sleep hygiene. You should have a set sleep schedule. And I'm going to tell you, I'm non-compliant in this portion that I'm trying to tell you guys to be compliant about. But, I own my stuff and I admit my mistakes because I'm like 100% real like that. You have to set your sleep schedule. And have a set schedule helps normalize your sleep. So if you're going to sleep every day at the same time and waking up every day at the same time, your body's going to thank you for that.
Well, and I've heard that the bed is for two things.
Sleep and sex. Just say it. The two
That
S's.
Is it.
Sleep and sex.
You shouldn't read in bed. You shouldn't watch TV in bed. You shouldn't be on your phone in the bed. If you're in the bed,
you're either sleeping or sexing.
Exactly. And so, and because... You know exactly where that came from.
I know.
But I'm like, when I thought about it, I'm like, yeah, that's probably a really good, I guess I'm just lucky as of right now in my life. And of course, this is all subject to change. You know? I'm sure menopause will hit in so many years. And then I'll be like, this is what Rosa was talking about with this insomnia.
When you're up all night and your brain can't shut up. Yeah, when I'm sending you those emails at 11 and 12 o'clock at night.
Yeah. Hey, something? You email me anytime about Elon, okay? Because I read that the other night too.
Yeah, I'm that one. I'm the insomniac. And it's probably because this is where I need to work. I need to work on having a schedule and sticking to it. And, making sleep a priority. We all have like a lot on our plate. I think even more so since 2020. And our lives become like a little overwhelming sometimes. We get a little anxious. We're always thinking about the next thing that we have to do. And sometimes it's hard to kind of like...
shut it off.
Yeah, turn that switch off. So we need to make sleep a priority. And I'm saying that, I guess, out of the horse's mouth because I need to do that as well.
Maybe I should have did the top part of these.
Yeah.
You should do
How about you do the last part of these because then it'll make me feel better.
So make gradual adjustments, Rosa.
I'm trying.
And that's what you want to do. You do want to slowly make changes because if you just try to make one change and say, I'm not going to do it anymore, I think you're
shortchanging yourself.
Well, I don't think
and you're setting yourself up for failure.
Exactly.
Yeah.
So maybe say, okay, I'm not going to read in bed or whatever your thing is that you do in bed. You're not going to be on your phone or on your computer, or maybe some people sit on their bed to do something. Just quit doing it because your body is connecting bed with work.
Absolutely.
Don't overdo it with naps. Do not nap during the day if you can't sleep at night. That seems like common sense to me. But my grandfather does this, and then my grandma was like, he was up all night. He's having one of his spells. I'm like, don't let him sleep during the day. It's not a spell.
Yeah.
He's
throwing
off
his whole circadian rhythm right there.
Yes.
Yeah.
Follow a nightly routine.
I'm rolling my eyes. You just can't see it.
So you want to try and keep your routine consistent and 30 minutes for winding down. And this may be something as simple as getting in a shower, brushing your teeth, putting your lotion on, whatever, and then going to bed. And going to bed.
For a minute, you was going to use the bed for sex.
Well, that's one of the S's. Okay.
You were in the shower, you were brushing your teeth, and then you was lotioning up. So.
Well, I mean, you never know what's going to happen.
Is one of the S's asleep? So, okay.
So that's okay. You want to unplug from electronics 60 minutes before you go to bed. I don't do this. I mean, if I did all this, I'd be asleep at 5.
Wow.
But what that does is it just generates your mind. You're constantly stimulating yourself. and you can't turn it off.
Absolutely. And if, we naturally make melatonin, yes, you can buy supplements to help, with that. But every time that backlight and bright light flashes, it's throwing off your circadian rhythm.
Yes.
And it lessens the amount of melatonin that your body releases.
Mm-hmm.
So it's very important to just, Rosa, turn the TV off.
Mm-hmm. Right. You can do things like dim your lights if you have that ability. And what that does is it is another signal that, okay, it's nighttime. I need to start producing melatonin so that way I can go to sleep. You can try relaxation. We did a podcast on meditation and mindfulness and breathing, different things like that. This is so ironic. There are apps that you can get on your phone that will actually help with this, that actually have like a black screen that do this. So that way you're not looking at your phone, but it's going.
It talks to you. So you don't have to be interactive with your phone. So it's telling you, take a deep breath in.
Don't use your phone, but there's an app for that.
Let your breath out.
Right.
Yeah.
And it does it for a determined amount of time. Usually like 5 to 7 minutes. I think that for most of them, you can alter it. Mm-hmm. I've thought about that for my husband. And then I think it would bother me. So he'd be all right. Don't toss and turn in bed. And so if you get in bed and you're just flopping around and you're not going to sleep, you need to get up. You need to go do something. And even if it's just for 20, 30 minutes, go read, do some meditation. Don't watch TV. Don't get on your phone. But just try to do something that'll quiet your mind. And then try to go back to bed.
You definitely want to get daytime exposure because the sunlight is one of the key drivers of your circadian rhythm, and it encourages, quality sleep. You want to be physically active. You don't want to smoke because nicotine, is a stimulant. Mm-hmm. And if you're having that cigarette right before bed, that's going to give you that dose of nicotine and it's going to keep you up and awake. You're going to reduce the amount of alcohol that you consumed, which we've already talked about that because 1, it's not really good for sleep. And 2, it may stop you from breathing. Mm-hmm. And you're going to want to cut down on caffeine in the afternoon and evening. Which I do practice. Okay.
Yes, ma'am.
I do practice this one thing.
I do this one.
Ashley.
I do this one.
Ashley, she's the one drinking coffee and then can go straight to sleep. No, okay, I'm done. I'm done shaming. So caffeine is also a stimulant, just like, nicotine is. And so its job is to keep you awake.
Right.
So just be aware of how much you're consuming. And like when to stop. Like my rule is I can have however many cups I want until noon. And then after that, I can't drink anymore. And so, yes, I might be a little bit of Oscar the Grouch afternoon.
She's not normally. But I most certainly would be if you told me I couldn't have any caffeine after noon. And caffeine's not really, I don't drink a lot of soda.
I don't either.
I drink water.
Yeah, I don't drink a lot of caffeinated. Coffee is my only caffeine that I drink. I'm not into Mountain Dews or anything else like that.
Yeah, I don't do a lot of that. But
or those energy shots. I don't understand that either. No. But you definitely don't want to eat late for Pete's sakes. You're going to sit there and eat a 4-course meal and then like lay down. I don't know about anybody else, but I would have so much acid reflux. Restrict your in-bed activity. As like we've said before, the 2 S's should only be done in your bed. Sleep and sex, and that's it. You should optimize your bedroom. You want to make it tranquil.
Sure.
You want to make it zen and peaceful and have comfortable mattresses and pillows and that 1,000 count of thread. And you want your bedroom temperature to be cool but comfortable. So they say setting your thermostat to about 65 degrees is perfect because then when you put your blankets on, you're not too hot.
But then I want to get out of bed in the morning.
Well, that's true. You might be cold when you get up, but you can always turn the heat up. Use, blackout curtains. If you're a third shifter, I mean, to me, you already got kudos for me because that's not a shift I can work.
Well, no, but blackout curtains and earplugs.
Yes.
I mean,
they work wonders.
Yeah. I mean, and like I sleep with the fan on, and that just kind of blocks out.
Yeah, it's your white noise.
Yeah, noise and stuff. Like people who have the fans that don't make any noise, I'm like, no, just give me like a traditional old fashioned box fan that makes a noise, and that kind of just, I don't know, gives that white noise that helps me sleep.
Although my Alexa has an app that plays.
Of course.
Yeah. Okay. Moving on.
Play like a box fan.
Also try calming scents. I mean, we all know that lavender has this really soothing, calming effect. Maybe if we all took a minute or two to smell some lavender, the world would be a happier place and a much rested place.
Like we've been saying the whole time, it's very individualized. And some of these things a lot of people I think would automatically do. Mm-hmm. But if you're a nurse and you're trying to educate patients on it, and sleep hygiene and it's wearing their CPAP or their BiPAP or their ASV or whatever machine that they have or whatever device, it's just about making them comfortable. And there's so many different options out there now that no matter, I think, what problem the patient has, a lot of it can be worked through.
Absolutely. I 1000% agree with that.
As always, we will link our references to our website, thenursingpostpodcast.com. Be sure to subscribe to our podcast on your favorite platform, and you can leave comments there too. Thanks for listening to The Nursing Post.